Well, tonight our featured presentation is entitled Emotional and Social Wellness for the Modern Day Teenager, and it's presented by Dr. Sherry M. Simpson, who is currently an assistant professor of psychiatry at Baylor College of Medicine. Clinically, she spends her time at the Covenant House, a teen homeless shelter, and in private practice. Dr. Simpson provides pharmacologic management, treatment, individual, family, and group psychotherapy, bibliotherapy, and infant massage. She is board certified by the American Board of Psychiatry and Neurology in adult and child and adolescent psychiatry, and she completed her internship, residency, and psychiatry fellowship training at Menninger Department of Psychiatry and Behavior Sciences at Baylor. Dr. Simpson graduated with general honors from Meharry Medical College and completed 1 year of graduate school in the School of Public Health here at Morehouse. She holds her undergraduate degree from Howard University. Application for CME credit has been filed with the American Academy of Family Physicians, and due to the holiday schedule, currently CE credit is pending. There will be an extended question and answer session at the end of the presentation. However, you can feel free to submit your questions and comments throughout the presentation, but we won't be able to address them until the end due to the volume of information that will be shared. So with all of that said, ladies and gentlemen, thank you, and let's welcome Dr. Sherry Simpson.
All right, well, thank you so much, Sabrina. We're going to go on and get started. It's about 7:32, and I have about 59 slides. And let me just say this. I'm typically a talker, and I typically like to have fun during presentations. So I'm going to be telling jokes and just giving you some of my own personal patient scenarios, and so that it's fun and also informative. Disclosure statement: in compliance with the American Academy of Family Physicians, I hereby declare that I do not have any financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. And I want to first start off with, again, my acknowledgments and thank yous. These are all the people that are in my personal network of here in Houston and also in Atlanta who helped me in my mental health, as well as I also want to thank Morehouse School of Medicine and Miss Sabrina Jackson, who was the coordinator of this program. I'm really feeling honored tonight, so hopefully we'll have some fun and learn a lot tonight. Objectives. So before I did my PowerPoint presentation, I did my objectives. And then when I was doing my PowerPoint presentations, I thought, wow, these are a lot of objectives. It's a lot. So I did have to make just a few modifications because, and the reason why this is important is that I'm looking at who's here today. We have, looks like 4 or 5 psychiatrists and 1 primary care physician. So the psychiatrists know that this is a lot of information to try to stick in one presentation. So we'll do, I'll touch a bit on, and I was getting a text from Sabrina, and so then so it's a lot to fit in within 1 hour. So we're just going to try to touch on a bit and then keep going. So this was the first objectives: review mental health definition with the focus on factors specific to adolescence, increase understanding of the most common mental illnesses, including ADHD, opposition defiant disorder, bipolar, depression, eating disorders. So I have removed substance abuse, and during this talk I won't be able to talk about substance abuse or sex because those are just, and also eating disorders, but so much because of the length of information that each of those could require. Improve mental health treatment planning in the clinical setting, and review social media guidelines for teenagers. So those are our objectives. And since we have mostly psychiatrists here, I'm going to just be more brief on this part because we know this, but I do want to touch on it because I think it's important that I haven't been practicing but about 5 years, and I graduated in 2007, to be really 5 years in June. And what I have found is that just the definition of psychiatry, I think for me, is too limited. And I think that it is our specialty, it is my specialty. It's a medical specialty devoted to the study and treatment of mental disorders. These mental disorders include the various affective, behavioral, cognitive, and perceptual abnormalities. But it just in the clinical setting, it just feels as if it's more biologically driven, and that's really the focus. Is a focus on illness and deficits. And for me, it does not. Even though the trends in medicine across all specialties are moving towards resiliency, recovery. I think the psychiatry as a whole has been really deficit driven. So I think the mental health definition is one for me that allows me to assess and incorporate strengths and protective factors into my clinical assessment. And I also think for just me clinically allows me to promote the mind, body meaning brain, including the brain, body, brain, mind, because we know the body, the brain and the mind are not the same, and behaviors and environment. So for me, so I use the mental health definition when I'm talking to families. I love the definition of mental health. I absolutely love it. I read it, of course, in residency, and Kolb was a psychiatrist. I think he was out of Columbia. He was a man before his time, and this is the definition that he devised back in '68, and then it was modified by our own Dr. Satcher in 1999, who was the Surgeon General. But I'm going to read this definition, and I actually give this definition out to my patients. And I always chuckle when I read it, because most times when I first read it, I said, "Oh my goodness, this is why most of us feel what we feel, because most of us don't have this. We haven't obtained this." So I'm going to read the definition. It is: a mentally healthy adult exhibits behavior that confirms an awareness of self or personal identity, coupled with a life purpose and a willingness to perceive reality and cope with its vicissitudes. To be active and be productive. And, excuse me, I'm going to take 1 minute to do this. Let's see. Trying to do something technological here for our presentation. Okay. To be active and be productive, to respond flexibly to stress, and to receive pleasure from a variety of sources, and to accept limitations realistically. And that's a wordy definition. And the modified one is the one, again, written by by the Surgeon General in 1999. Mental health is a state of successful performance of mental function resulting in productive activities, fulfilling relationships with other people, and the ability to adapt to change and to cope with adversity. So this is in terms of this talk today, the first part of the talk will be more so a mental health check, and the second part of the talk will be when there are concerns on the mental health check that we need to think about. And I put this sort of caveat at the bottom, because I think that for me, the mental health definition, even though I think it's comprehensive, does not incorporate the context in which our patients exist. And that is critical for them to be able to obtain mental health. And also, in how I think about the biological and psychological, is that biological factors and psychological factors can disrupt, undermine mental health, and the inability to achieve mental health can cause biological and psychological factors. So this is how I try to talk to my patients and talk about it in this language, because as psychiatrists, we know, but I see a couple more primary care people have come in, that sometimes there's a focus on medications being the only treatment versus psychological therapies being the only treatment, and it's unclear how the two interface. So the mental health check. there is not, psychiatrists, we know that there's not a mental health checklist. We are the checkers. We assess, but there's not a checklist that would help primary care physicians assess for mental health and mental health problems. And so I've sort of devised one, sort of a brief one that I think would be helpful. How can we get the discussion started with our teenagers? That typically this is how most of my interactions used to begin. How are you doing? How is everything? And most people respond with the rote, fine, good, normal. And oftentimes we know that may not be the case. So I think some other questions, and this came off the Mental Health America website, and again, this is for our primary care clinicians in terms of helping you all get more information from your patients, is how do you feel about yourself? How do you feel about others? How you meet the demands of meet the demands of your everyday life? And I added this one: how do you take care of this? So this is, again, these are 4 key questions that are part of a mental health checklist that I have sort of created. This did not come out, but this was supposed to be the Maslow's hierarchy of needs. And if we were all in person, I would ask you, have you seen this slide? And so right now, who has heard of the Maslow's hierarchy of needs? So shake your head to yourself. Yes, I've heard it. No, I haven't heard it. So even though I don't know what anyone said, I would imagine most people have not seen this hierarchy. And what it was, and where is my pointer? If this diagram was up, it would be a pyramid. And on the bottom of the pyramid would be basic needs. And at the top of the diagram are the self-actualization issues that we want our patients to focus on. And I like this paradigm, this model, because it really allows us to see that if we agree, because you don't have to agree with it, but it does make sense. And if you have time after this presentation, I want you to just Google it real quick, because it's everywhere on the internet, that if a person's basic needs are not met, which is the bottom, which we spend the most time doing, that it's hard to achieve the self-actualization that we're stressing. So, and working in a teen homeless shelter, the kids see me for medications, they see a therapist, but because the basic needs are not met for most of them, it is very hard to get them to work on the polytrauma and all of the other issues, the identity issues that they're dealing with. But I thought this was important to put in. So the mental health checklist, I'm going to move our cursor back up. So we're going to be looking at identity formation, relationships, peer and family, coping and adaptability, sleep, dietary, social activities, exercise, and self-esteem, all in one, and also the context. And the reason why identity formation is first, because according to Erik Erikson and developmental theorists, identity formation, however it is achieved, is the primary goal of adolescence. And that identity formation, though, does not just include vocational or educational. It's also social actualization and relational actualization. So it really is a variety of ways that our teens think about themselves that we need to know about so that we can clearly assess them. So the influences on identity, and there are a lot. This is a list that I compiled. That last one on the bottom is media, and ethnicity and nationality. This is important. I think it's important for everyone. I think how it comes into play is I'll give an example of how it has come to play with clinicians and myself, and that non-Black, I've had several discussions with non-Black clinicians who don't think of themselves, who don't think of ethnicity in any way. And so, my challenge to them was, if you don't think of your ethnicity, then how can you think of my ethnicity? And just because you don't think of your ethnicity, that doesn't mean that I don't think of mine. So I just wanted to make sure that that is something that is discussed. Culture, religion, identity formation for teens is an hour-long. We could talk about this for an hour, but I'm just trying to list all the things that I'm hoping that we are thinking about when we're interacting with our teens in terms of identity formation, and also just how they think of themselves. Socioeconomics, class, IQ, educational level. This was where's my point again. This is a big one that I have been dealing with in my practice. Is my children, my teens with Asperger's and just really high function autism. They know something is off. They know something is off. Sometimes they can discern what's off. Sometimes they can't. But their relationships are not many times what they want them to be. And there is oftentimes an anxiety and a depression that results because of it. Sexual orientation is another one. Sexual orientation, and I've separated them because they are different. Sexual orientation, gender role, gender identity are all different issues, even though you may have a teen who, let's say a young woman who proclaims that she is a lesbian and looks masculine. The fact that she looks masculine and the fact that she is lesbian and orientation are two different issues that have to be teased out. And also health and medical status, that's a big one that I also see, especially in my children and my teens with chronic medical illnesses. So those are my children with cystic fibrosis, sickle cell anemia, just a lot of issues with how they think of themselves because of that, and also the media. When I think of that, I'm always thinking of the hypersexuality of westernized media and how that impacts how our teens think about themselves sexually. Identity formation, I'm going to move us through because half is going to be the checklist and half is going to be the other part. So we're already at 7:46, so I'm going to keep moving. Identity formation, it is, again, the primary goal of adolescence. And over the last 15 to 20 years, that completion of that formation has shifted. And let me just say, this is my experience, that identity formation it's not fixed, that someone can achieve formation in one area of their life, and they may change and they may achieve it in 3 or 4 areas, but not one. But there's still the hope is though that there is movement, there is exploration within the sort of realm of finding out who they are. That is the most important thing. The ages are 12 to 20, and I probably would push that back to 21, 22. And these are the 4 ways in which identity formation is achieved per Erickson. So there's the identity diffusion. These persons have not yet thought about or resolved identity issues. Identity foreclosure. These persons are committed to an identity. How I see this coming up in the clinical setting, how it came up for me in the clinical setting, is that I was an identity forecloser. I knew early I was going to be a physician. I just knew it, and all my efforts were focused on being a physician. But when I look back, when I'm 35, I look back and I'm like, I like being a physician, but what else could I have done? But sometimes as a clinician, because we foreclose early as physicians to be as kids, as teenagers, then when we're clinically, when we're helping teenagers, we sometimes can be a bit judgmental. Let me say personally, I was a bit judgmental on my kids who come in who say that they don't have any ideas about what they want to do, which is unlikely. It's usually some ambivalence, and there's oftentimes some contextual issues that don't allow them sort of freely to be able to think about what they can do. Identity moratorium, these persons are experiencing an identity crisis and are actively asking questions. So this is what we want. We want our teens to be actively asking questions about themselves in a variety of ways so that they can figure out best who they want to be, and then of course follow behind that is how they can move towards that. And identity achievement, again, is solve those identity issues, but I think that could be, it's not malleable, but it changes. It's not fixed. So sort of salient. Factors to consider in a clinical setting, take-home points. This is my experience. Pseudo parentification or pseudo maturity in my kids, who the parent is, and I'll give an example. This is what I saw mostly in my El Centro de Corazon clinic. The parents were Spanish speaking, had very limited education. The teens were westernized. They did a lot of maneuvering of bills, of multiple systems on behalf of the parent. It does affect how they think of themselves. Intergenerational cultural dissonance. I've seen that a lot, the most with my East Indian families, the ones that come much more structured and defined roles for women, and then they get here. I even had a young woman who was so paranoid because she had had sex that I couldn't mention anything about it in a note. I couldn't, and she wanted to have vaginal tightening. She was asking me about vaginal tightening because she was so concerned. She was so concerned about her husband-to-be, that her parents had arranged this wedding, that they would find out she wasn't a virgin. And she was overwhelmingly depressed because she also feared death. So these are issues that we have to be thinking about. Hispanic teens who've been raised in the U.S. but are not citizens. There's a big gulf of resources that they lose once they leave high school because they're not U.S. citizens. Disenfranchised ethnic groups with a cultural tradition of masculine defensiveness. So when I'm thinking about my teenagers, my Black boys, my Latina boys, I'm thinking about their socioeconomics, their class. I'm thinking about all of this and how they are defining themselves as men and will define themselves as men, and also teen child prodigy. It doesn't have to necessarily be prodigy, but also how our teens, if there's a teen that's designated as the child that will get the family out, will make a way for the family, even if it's through education, if it's through sports, if it's through beauty, in terms of, I was thinking of all the tots and tiaras and how that progresses when children are teens, as well as the singers. So I've seen a lot more focus on actors, actresses, and parents who want that child to be successful, and how that impacts how the child thinks about themselves. Relationships. I don't know if you've seen this. I know my child psychiatrists have probably seen this, but I'm gonna hold this up. It's the facts for families, and there are about 100 of these that are on the ACAP website. They have an index. I wrote the relationship family part like this specifically because most parents and children don't talk about the process. They don't talk about what is about to happen, so they're not prepared. So then things get chaotic, they get out of control, and so as clinicians, we have to talk to our parents when we have tweens, that there is a process, there are things that will change, and how can I help you move through that. The first one is create an atmosphere of honesty, mutual trust, respect. In ones and brackets I added because I think that there has to be a deliberate and intentional discussion about empathy, morality, and mentalization. We know mentalization is a term that Fonagy and Bleiberg and their cohorts have devised, which is thinking about oneself, our own thoughts, beliefs, experiences, behaviors, different from another's, and being curious about what that difference is. So not sort of foreclosing on what our thoughts are of another, thinking about them and all the different ways they could be thinking about the same issue, but first asking them what they think. Clinicians help parents to honestly assess their parenting methods that may be based on myths. Their parenting methods may also be part of the problem. And I'm going to talk about the concept of the identified patient in a bit, and that this is a critical point when talking to the families. Also, we know about peers. It's so important, and the clinicians, your take-home point is at the bottom. Assessing friendships, the quality. are their friends? Mostly girls, mostly guys. If it's girls, at this point, in teenagers, they usually have guys and girls. But what if you have a teenager, a girl who only has guy friends, and vice versa? What is that about? Because typically, as we move through the teenage years, we have a balance of same-sex and opposite-sex friends. Quantity of friends. Do they have not the expected, but a reasonable number of friendships, both at school and at home? There needs to be a balance. I have some families who they have friends only at school, and there are no interactions with friends after school and on weekends. And also the duration of friendships, if any friendships have changed, are these long-lasting friendships, or are these or is it the patient of yours, they have one or two friends for a brief amount of time, and they're always sort of replacing friends with other friends. Activities, what do they do together? Role, dating expectations, and sex. We won't be able to talk about sex, but we need to talk about sex. You got to talk about sex. What I found most helpful in the clinical setting is when I'm working in my FQHCs, when my nurses give their sex assessment, do you have sex? How many times have you had sex? Just sort of blanket questions. I find that those assessments are the most accurate. It also is important to check the information because a way that I've also been able to identify as childhood sexual abuse is when I look at the nurse's assessment and then the child tells me what their personal experiences are. They've had no boyfriends, they've had no friendships, they've had no relationships, but yet you look at the nursing assessment and it's a lot of sexual activity going on. So it may not be childhood sexual abuse, but there still may be some unhealthy childhood sexual behaviors that teen is not telling. So I think that's been I've been surprised about how helpful that's been. Coping mechanism. There are different types of coping mechanisms. Walker talks about this. This was sort of talked about in terms of pain. But I think that they can be helpful across all realms, including mental health. Passive coping is what we want to look at. It reflects strategies that avoid confronting pain, such as avoidance, denial, wishful thinking as a considered maladaptive. So we got to figure out how your teen is coping. Back to the checklist questions before, which was, how do you get through issues in your life? How do you do that? What you're doing, you're trying to figure out how they manage their emotions, or if they monitor their emotions, which many teens don't do. And then if they do monitor, how do they manage and channel that? And how do they react? Great question is, are you in control of your emotions, or are your emotions control of you? Boom. Are you in control of your emotions, or are your emotions control of you? I absolutely love that question. Again, teens must learn how to monitor, understand, modulate their emotions, and know that they are in control even when they don't want to be. Even though they don't want to be in control, they're still in control. In terms of how they take care of themselves, I sometimes wish I had done a sleep fellowship, because I get so many questions about sleep. I just get overwhelmed by these sleep questions. Sleep complaints is overwhelming. We know that sleep problems can cause irritability, difficulty concentrating. We will be talking about ADHD, and before I even do any ADHD assessments, I'm asking about that sleep. I'm like a sleep Nazi. I'm like all over this sleep, because I wanted to find out, because I always, with my teens, it's always an issue, typically, not always, but sometimes. When I take a sleep history, you assess for psychiatric symptoms. Are you a worrier? Are you a worrier? I'm thinking generalized anxiety. Maybe that's what's keeping you from sleeping. Again, that there are no medications indicated for sleep in adolescents. There are none. I'm always surprised when I see teens taking antipsychotics as a sleep aid. I typically don't do that just for sleep unless I've tried almost everything else. What am I doing first? I'm doing Benadryl. If there's not a history of a paradoxical reaction, that means they're over the top versus being sleepy. And then I'm also going to melatonin, but I'm also going through my naturopathic discussion about those. They've not been tested through the FDA, but I am discussing that, but I do recommend it. Then I'm going to trazodone. That's my go-to. And also, I don't do benzodiazepines for sleep. I try not to ever do benzodiazepines in teens or children unless I have to. It's a last choice. And all my GABA receptor medications, I don't choose those as well. Dietary habits and eating in terms of the mental health checklist about how you're functioning. I'm a stickler for sleep. I'm a stickler for what we eat. Encourage for your clinicians, you want to encourage your parents to discuss and plan meal times without media consumption. Try to get them off the TV, not watching TV. Again, that's going to help us focus on what we're eating, and also we're trying to build interpersonal skills and relatedness and all of that stuff that's needed that you have to do face to face. Coordinate shopping lists. I also go to a lot of fast foods to see what is offered. I'm also challenging my teenagers and my parents to do a side salad with the chicken, with the burger, or we're gonna do French fries. We gotta do water. Also, to be culturally appropriate, you got to know what else is out there, what is going on at Escalante's, what's going on at Taco Cabana. Got to know about burritos versus tamales or chalupas. You got to know what's in what. So I randomly would just go to a restaurant and look at the menus, and so then I could better talk to my families. Dietary views and habits. Clinicians, we have to ascertain family perspective on body habitus. How do they think about their weight? How do they think about about being overweight or being underweight? And let's say you have a teenager who's overweight. Are the family dynamics such that that child can't lose weight, or the child is the holder of the issues that's manifesting through the weight gain, or is manifesting through not eating enough? So we got to be clear about how they think about body image and what messages are given to our children. Family and cultural influences of food, or on food, or I guess of food. When I was working at El Centro, my clinicians, all the clinicians were Hispanic, and we would always have parties. I mean, we would be straight kicking it with parties, and we talked a lot about, Hispanic culture. We eat. So what do we do about that? How do we modify, the tamales and the rice and beans and all? How can we do that differently so that we're healthy? Eating habits and choices have to be assessed. Mealtime occurrences and expectations, lunchtime and after school options, and adequate nourishment. I put that in because that's something I wasn't thinking about until the last couple of years. That, do your teens have enough to eat? Do they have enough to eat? So if they eat food at school in the morning, on the weekends, where are they eating? Where are they eating, and what are they eating? And that has to be discussed with our families. Again, and never, of course, in a judgmental or critical way. Social activities, exercise, and self-esteem. I lumped all of those things in together on purpose. Psychiatrists, we know how self-esteem is established. I'm going down to the fourth bullet here. Self-esteem. It is how we think of ourselves, our beliefs and our thoughts about ourselves. And that, as children, as toddlers and children, we know that comes from what mommy and daddy and our caregivers think about us. It's what they think that we begin to think. They think positive, we're positive. They think negative, we're going to think a lot of negative thoughts too. Over time, though, our competence, our own effectiveness, our own acceptance, our own beauty is what begins to drive what we think of us. And so it's critical that we think about self-esteem bigger than just activities and academics. Because there was a big, we know there was a big self-esteem push that you work on a teen's self-esteem by getting them in activities or making sure that you trying to find something that's good about them. And personally, being religious and spiritual, I think that there is a goodness to us just because we are. Activities are important. They do a lot of things: enhance learning, literacy, creativity. Exercise is needed physiologically. Also, it helps to help us to obtain mental health. But there's also, in terms of self, and those two things impact self-esteem, there's also got to be a separate piece in there as well. That's my suggestion. In terms of clinicians, we want to assess familial perspective and value on activities. Back to your cultural dissonance. You have a first-generation U.S. teenager. You have parents who come from Mexico, Nigeria or another place where activities were not the focus, you may have to discuss what the importance could be. As well, provide resources for after school, weekend, summer camp, volunteerism. I love that. I'm always giving out a whole bunch of resources. I always know about summer camps. I'm always pushing activities to my families who are not aware of those things. I'm always helping them think about what could be helpful. Discuss overscheduling and underscheduling. Critical, over and under scheduling. Also want to talk about the family temporal balance. Most of the resources within the family focus on one child or two children, and the family and the parents are not the parents don't get to focus on what they need to. So it's family temporal balance. Encourage parents to assess if activity withholding is an appropriate punishment, especially in our teens who we want active. I know they were Skyping at 10 o'clock. They weren't supposed to. You know they were out late. The grades are failing. Activity withholding may not be the best bet. Context. This was a sort of a crazy slide. I couldn't figure out even how to put it in here, but there is a context that we have to think about, and this is just something for us for you to just take home. That a child, a teen, a person needs a safe, clean, stable, and I mean stable. That it means it's not a whole bunch of different people in the household. They're not an excessive amount of moves going on that have gone on, and a loving home. I have had to say to several parents, no more moving. No more moving without more forethought in why you move and where you move. Now, economically, that's another issue. But if you have capacity to stay and to be insightful and I guess resourceful in finding out information before you move, you've got to do that. Personal safety, we know you've got to know this. Witness and or experience intimate partner violence. Just because you have a teenager who is a lesbian or homosexual. You still have to assess for intimate partner violence because it still goes on. Cyberbullying, live and in vivo. You have to also discern whether or not the person is a victim. You have to ask whether or not they've been an abuser. If they are an abuser, you have to ask that specifically. You have to also ask about the observer because we know with bullying it's that I was trying to get my triangle up. Can you see my triangle? It's that threefold point. It's the victim, it's the abuser, and the observers. Community disruptions. Another example real quick. I still have my Hurricane Katrina survivors here in Houston who say they are still affected by Hurricane Katrina because the displacement was such a significant issue. Even though the Houstonians, we're fine because we love them into Houston, but I have to be mindful that the Hurricane Katrina transplants who are here still may be affected. So we have to be clear and be broad in how we're thinking about. And also the immigration detainment history. It is key because some people have horrific trauma, a part of their immigration and transition from Mexico to the U.S. Again, some of this is just horrific. So we have to know that as well. So mental health problems, illness, and disease. So back to our primary care specialist. You know, I'm not a behavioral health specialist. I'm not that. I'm not a behavioralist. And when the phrase started to change from mental health to behavioral health, I really initially was offended. I was like, what is this? That's not what I am. But at this point, I don't really care what you call it. This is just personally. Whatever needs to be said to get you in to see me, that is fine. If it's mental health, if it's emotional, if it's behavioral, stress, whatever you need to say to get a person in, that of course not ever lying, of course, but whatever, if you need to soften that word, then do so. Mental health concerns, when to refer. So this is also from the Facts for Families off the ACAP website. The bolded areas, of course, are the ones that you wouldn't refer necessarily to me, because you would send them on to 911 or the emergency room. And for a primary care physician, you've got to have a process in place at your agency, at your office, about what to do in emergencies. The ones in brackets are the ones I added because I think that they're important. Marked change in school performance and relationships. If the relationships in your child's life have changed, that may be a sign that the child may need to be referred. Also, marked social deficits, withdrawal, and shyness. I probably have at least 1 or 2 teens a month who come in, and the families will say, you know what? They've never had friends. They've never functioned. And they're like 16, 17, 18. Never really done what teenagers do. I had a 25-year-old who has never been on a date. Never done anything. And he was 25 when he first came in. So, and also when I think of social deficits and withdrawal and shyness, I think about depression and anxiety. I also think about psychosis. I think about substance abuse, because how are they managing what they need to manage? So it's a lot of comorbid things that I think about with social deficits. I also think about undiagnosed Asperger's. But also, look, real quick, back to mental health referral, but also just if people have questions or concerns. But I think that as providers, as interdisciplinary clinicians, that my patients know that you will go to the OB-GYN, or we're going to have a problem, because I'm going to keep on you on that. You will go to we're going to continue to talk about the primary care physician. And if it irritates you, you will probably end up leaving. But I can't do this alone. And in any patient who tries to get a primary care clinician to collude to not send them there, then that's an issue. Also, a mental health referral should not be because of default. It shouldn't be as a last resort. If you don't take this medication, if things don't change, I'm sending you to the psychiatrist. That is not the way that we want primary care to think about us, because we're all working together. Psychiatric evaluation, what to bring? Oh, prior evaluations. I had a family they knew the child had been diagnosed with Asperger. Multiple people. They didn't bring in that one thing. Why? Because they wanted a fourth assessment. They wanted a fourth assessment. Okay, good. All right. So that's another issue. We have to work through that. But what I want my family to bring, I want them to bring everything they have, all evaluations, psychiatric, psychological, school, information. I want to be able to talk to people. So any contact information that they have available, I want that. Who comes to the visits? I want both parents at the visit with the teenager. If it's lots of conflict, of course, I wouldn't want both families, both parents, if they can't manage themselves. But if they can manage themselves, I want both parents. What to expect? 1 hour visit. For me, it's 80 minutes, depending on what site I'm at. And we're going to talk about history, medical problems, functioning, relationships, a lot of information about the parents' own experiences and health status, which oftentimes they're not expecting, but again, about the context, the context is the parent's context, and the parent's context is their own parent's context. So all that information is needed, and also to tell them that there may not be any treatment recommendations when they come. It may take 1 or 2 visits, and it may take a while, and so that they are okay with that. Or at least they're knowledgeable about that, because they may not ever be okay, but at least if they know they can accept it. So who is the patient? There's this phrase our psychiatrists know about the identified patient, also called the symptom bearer. It often comes out, the child or the teenager often is the symptom bearer of the family tension conflict. And so it is critical that, and I bring this out to my families, that it won't just won't be how I can fix your child. It really is going to be an exploration and evaluation of how you all are functioning, how that function impacts the child, and how the child's symptoms impact the family. So that is critical. It's a critical concept that I say early, if I think that there is this sort of identified patient phenomenon brewing or perspective. Common psychiatric illnesses, anxiety disorders are the most commonly diagnosed, between 4 and 20%, 2.8 and 27%. So it's the most diagnosed. Why? Because there's so many disorders that are under the umbrella of anxiety disorder. Generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder. There is a separation anxiety disorder, all your phobias. ADHD, 9 to 11% prevalence rate. Oppositional defiant disorder, ADHD and oppositional defiant disorder often go together. Major depression, that prevalence, the point prevalence at any one time is about 3.8. The lifetime prevalence for teens is about 19%. So about 1 in 5 teens we can expect will be diagnosed with could be diagnosed with a major depressive issue. Substance abuse, that prevalence is based on the substance. We won't talk about that here because it's just that's a whole topic. Bipolar, but it is something to be mindful of, and you have to assess. I'm sort of up and down about random drug testing. It really is an individual patient decision. Bipolar disorder. Oh, we're going to talk about that. And personality disorders, we're not going to talk about that, but we are going to talk about bipolar disorder, but because that there is a lot of just conflicting information about that. So we look at the prevalence, we look at anxiety disorders, ADHD, oppositional defiant, depression, personality disorders, then bipolar disorder. Most of us, everybody here is a clinician. If you're young, if you're older, then you learn that you don't diagnose it until 18. That's still what's in the DSM-4. There's new information, there's new discussion about if the diagnosis, if we think it's personality disorder, you need to go on a diagnosis so you can go on and do what you need to do and not wait until the child is 18. In this study, this is back in 2005, I love Current Psychiatry because it's easy, that journal, it's easy to read, even though I know it's not nearly as clinical as the Green Journal, but whew, that Current Psychiatry, that's just, I typically use that because it's quick for my, it's just quick reading. In this study, 25% of teens and children were diagnostically homeless. And even though all of this information was gathered, still 25% were still diagnostically homeless, even after a lot of information was obtained. And I was sort of relieved, not relieved, but sort of reaffirmed that I am okay if I don't know what it is. And I know that there are a lot of psychiatrists who pride themselves on being able to diagnose fast, but fast does not often mean it's accurate. So if you see a patient, you're not sure, you're just not sure, and it's okay to be sure because a lot of times it's not sure, and it's impossible to get all the information within a 1 hour or even a 2 hour span. ADHD. Is there a teen onset? Well, we know there's a lot of controversy about adult onset and even a teen onset because many of these people do not talk about a onset of symptoms before 7 years. When a teen comes in and there's some question about ADHD, I'm asking about records. I want to see prior report cards, and I'm also, if there's any doubt, I'm sending you to psychological testing. When in doubt, psychological testing. Kids have Medicaid and CHIP. You will have to search for a Medicaid and CHIP provider who will do psychological testing. But if there's any doubt, you have to do that. If you think it's clear, if I think it's clear cut, then I go on to make the diagnosis, even though the symptoms don't fit within the DSM-4 criteria in terms of onset of symptoms. But I love the Conners questionnaires. I give it to everybody. I give it to both parents. Ask the parents to fill it out separately. Give it out to caregivers and teachers. But nothing replaces talking to a teacher, a school teacher. I love it. I absolutely even though it's hard, it's cumbersome because you're playing back phone tag like a zillion times. But once I get that teacher, every time I talk to a teacher, it reaffirms why I do it because I'm always surprised about the information that is often different from what the parent tells me. So I've had to push through it even though it is painful and it's time consuming. Adhd Pharmacology, we know that there are two classes of stimulants that are most prescribed, and medication is the first line medication for ADHD. They're non-stimulants, you have Strattera, and we also have Wellbutrin, you have your alpha agonists, you have your clonidines, your 10X, your Intuniv, and your Capvase, and also you have your naturopathic medications that I'm moving more towards, you don't prescribe naturopathic medication, but I do discuss it more. If a family comes in and wants to talk about it, I try not to be discouraging. I'm not necessarily encouraging, but I'm not discouraging. I bring them in, we talk about the FDA lack of trials, but I encourage them to bring in the information, bring in the name of the medication. If it's by Hispanic people who are getting families who are getting medication across the border, get the name. Oftentimes they can contact the doctor or a loved one there to get the name, and we'll do a drug-to-drug interaction search if we can. But then I talk about that often is not available. ADHD modifications. Remember, for your parents are the #1 promoter of their kids' success. If a parent is struggling to do that, then that's an issue that we focus on. How can I help the mother feel empowered and move forward? This is a website that I haven't used, but I just saw it. But it was a good website and talked about the difference between the 504 modifications and the IEP under the idea. So and it's important for your parents to know that. There's also a Facts for Families, again, a Facts for Families handout about this. Facts for Families comes in English and Spanish, also comes in Malaysian, Arabic, Urdu, and there's like 2 more that the Facts for Families comes in. So please use that. So bipolar disorder, and it's 819, bipolar disorder. Overdiagnosed versus underdiagnosed, just depends on what you're thinking about it, is whether that you think it's overdiagnosed and underdiagnosed. The issue is about the application of the criteria. That is the issue. If you strictly apply the diagnosis criteria, it may be the prevalence rate may be appropriate or maybe underdiagnosed per the other group who more loosely apply the criteria. There's no objective testing. We wish there were, because it would take so much of the subjectivity out of it. Also, they're misleading advertisements. The Abilify, you had the lady looking off into the the sunset, or I guess the outdoor, and mood swings. I keep hearing this, mood swings. So true or false? Mood swings is a part of the criteria for bipolar disorder. False. Even though people will say I have mood swings, I have bipolar, mood swings is not on the criteria in DSM-4. Bipolar disorder is about, in terms of hypomania and mania, and that is the issue, is the 4 days to 1 week. I strictly apply the diagnosis. I have a colleague who sits next door to me who doesn't. So our bipolar patient rates are different, but I tend to stick to this, give or take. Irritability +4, elatedness, so not just a happiness, elatedness +3. That lasts, there's a change, there is impairment. It lasts, there is a change, and there is impairment. Decreased need for sleep is not the same thing as insomnia. Not the same thing. Decreased need for sleep is not the same thing as insomnia. I have my teenagers say, I don't sleep. I can't sleep, I want to sleep, but I don't sleep. What are you doing during that time? Nothing, just watching TV, doing the same stuff I always do. So they may not be sleeping, but there's not necessarily an association. The other symptoms may not be involved. So still not the hypomania, the mania. Bipolar disorder, again, mood swings are not a part of the diagnosis. It is an impairment and a change. Bipolar disorder pharmacology, antipsychotics we typically use first. Seroquel and Abilify, those are the only 2 FDA antipsychotics designated for bipolar disorder. Based on cost, they may not be, we may not be able to prescribe it. Abilify is probably $1,000, maybe it's $800, but that is a lot of money, and it may not be on the formulary. Risperdal, haloperidol, and some of the other ones, some of the other atypicals, sometimes people use, but I usually start with Seroquel, Abilify, Risperdal if I'm using an antipsychotic. Mood stabilizers, Depakote, Lithium, Tegretol, Lamictal. I like Depakote. Depakote, for my teeny boppers who are having sex, not so much. My chicks, because I don't want them to have PCOS. I've never seen PCOS caused by Depakote, but it does occur. Unless I know my chicks aren't having sex, Depakote, I don't go for Depakote. But it's still a good medication. Lithium and Tegretol. Both Depakote and Tegretol have the neurotube deficits in pregnancy. So again, talking about teenagers, the identity, exactly what they're doing. I'm thinking about that and prescribing that. Also, Lamictal. I've seen that initial rash about 7 times, and I always ask parents to do a body rash check, and if they're willing, I want to see arms and legs too. Hey, let me see what's going on. From my lab, CBC with DIF, CMP, including lipids, including liver enzymes, lipids, TSH, and usually a HDA 1C. For my antipsychotics, of course, you're doing your lithium level, Depakote level, and your Tegretol level. Bipolar ADHD, a take-home point. This is a take-home slide. Overlapping symptoms, irritable mood, accelerated speech, distractibility, increased energy. So you can't use those, but those overlap so much with bipolar, with ADHD, that it's hard to use those as a way to say bipolar or ADHD. Non-overlapping symptoms: elated mood, grandiosity, flight of thoughts, racing thoughts. Don't use jargon when you're assessing for symptoms, especially in bipolar. I don't use jargon. When they say racing thoughts, tell me exactly what that means. I don't. I have episodes of doing of extra energy. Give me examples of what that means. Again, ADHD is persistent. Bipolar is a change. Oppositional defiant disorder. I think I've become an expert because I've had to become an expert because I see so much of this. Bipolar folks, in my teens, I hear about the explosive rage, but also in oppositional defiant disorder, I hear this too. Things happen, I get mad, I explode. I'm on 10. I'm on 10. Oftentimes with our oppositional defiant disorder, I find that they don't do a good job. Not just this disorder, but a lot of disorders. They don't monitor their inner world. So even though they may think that they're happy, they really could be already on a 7. So it doesn't take much to get them on a 10. And oftentimes, once they get to a 10, they get to 100 within this amount of time, and it's hard to pull them down. Again, primarily, opposition defiant disorder is interaction driven, but it doesn't have to be. It is about an emotional tug of war between parents and the child. You've got to do a lot of reestablishing of limits, being clear about rewards, expectations, goals, responsibility. It's parent-child focus. That is the intervention. A parent-child negotiation through therapy and counseling, and also maybe even a social skills group. These are 2 handouts that I give. I'm gonna keep us moving. You can just look at that. Feel free to copy, write them, give this out. But of course, make sure you reference that Marlowe and Company. Bibliotherapy, in terms of how to make it real in the clinical setting, I have like 75 different handouts. I'd only probably give out like 5 or 6, but I have a whole bunch of handouts just in case. I love this slide. I also love this slide. This handout, I give this out to almost every family, and that is trying to get them to communicate in a different way, one that creates love and respect and kindness and tenderness. Oftentimes, parents will say, yes, I'm doing exactly what I should be doing for my child. If I phrase it, do you set up an environment that your child feels loved and the bonds between you are loving, feel good, they're gracious and kind, respectful? Once I start going down those adjectives, it's like, well. So then it's like, well, this is a place to sort of get you all on track. Major depressive disorder is bread and butter disorder. We know what this is: 5 symptoms for more days over a 2-week span, plus or minus irritability in our teens, depression and psychotherapy, and depressant and medication. I'm going to keep us moving just because we can get through this. Prozac is the only FDA approved medication. Got to talk about the black box warning. Giving out the PHQ-9 or questionnaire has been so helpful for me. I used to be a non-questionnaire elitist. I was like, I'm not giving out a questionnaire. I hate questionnaires because I am the clinician. I can assess. No, I love those questionnaires because it's also, I love the questionnaires because it helps me not be subjective, 1, and number 2, what people write down is often not what they say. And that dichotomy has been really, it's just really telling. So I love it. And you got to document it. Eating disorders, overeating and undereating, eating disorder treatment, all of this is how I think about it, either over or under. In terms of medications, so we got to be careful with your olanzapines and thorazines. It can boost weight gain, but if you boost the weight too fast for your for your chickies who are sticklers for being thin, you could plummet them psychologically. But it can help sort of move some of that cognition rigidity away, sort of soften that so that they are more accepting. Again, treatment pearls do not assess using jargon. I start low. In terms of my medications, my antidepressants, for example, I don't ever start with the starting dose for my teens or my children. I start with, if the starting dose is 20, I start with 10. If I start citalopram, I start with 5. Fluoxetine, I start with 5. Why? Because I don't want side effects to be the reasons why we don't start it, why we can't use it. Oftentimes, by the time they see a psychiatrist, they've gone through so much turmoil trying to decide whether or not, I'm talking about parents, turmoil deciding that they want to do this. And I don't want side effects in 3 days to be the reason why we can't move forward. By the time I see you again, there still may not be any improvement seen. I'm going to tell them that. So in 2 weeks, there may not be an improvement, 3 weeks or 4 weeks. I expect that there may not be any improvements, but I do want to hear what kinds of things you're going to be doing to change the family, how the family will be working to change in the meantime. Your treatment team involves different people, again, so we're not colluding. The primary care folks are not getting forced, not feeling like they can't refer. And I'm feeling like I cannot send you back because you won't go. Again, everybody has to work together. These are my resources. I give out a 7-page questionnaire at the beginning of my appointments. Families can't fill it out. I expect that because it's not online yet. I say, family, mom and daddy, fill it out and send it back to me so I can read it before your next appointment. Again, I do questionnaires and scales. This is a website for the PHQ-9 that I hand out to everything. My bibliotherapy, handouts, books. I used to let folks now check out books. Now, you know what happens. I didn't get the books back. So what I do now, I give out the titles. I go on Amazon in the appointment and we go over, these are my recommendations, my facts for families, also the resource guide, and then that is available. In the social media, this is your guideline. This is all you need to do. It's 8:30. American Academy of Pediatrics recommends less than 2 hours daily of TV. This is so explosive. The teenagers are like, what in the world? They're cursing me out in their minds. They're cursing the parents out. But I love it. I love it. Online interactions do not prepare children and teens for real interpersonal actions. No big discussions on email or text. If you do that, it still does not replace a face-to-face contact interaction. It still does not. At the end are lots of acronyms that parents must be aware of. If a child or teen does not agree to letting parents, in my mind, this is my thinking, allow parents to have full access to everything, then I don't think that they should have it. The flip of that, if the parent won't bother to understand what their child is doing, then they can't have it either. So both people are involved in this. And I was going to say something else, but that's it. So thank you so much. It is 8:31. I heard Sabrina coming in, so I think now we're going to start the Q&A, and I'm going to mute myself so Sabrina, our program coordinator.
Phew. I know you must be tired. That was a lot of information, and we thank you so much. We do have a question. I'm not sure if you're able to see it in your Q&A box. And they're asking if you have any suggestions for a reference book for mid-level that's going into psychiatry. Your mic is muted.
Thank you for that. Mid-level meaning nurse practitioner or PA?
Yes.
Because if that's the question, I do not. I do not. But what would be the difference between the book that you would use or a book that I would use? Because the books that I use, other folks use besides me.
I'll wait for their answer. Can you mute your mic for us? Oh, you did. To our audience, we apologize for the feedback. We're having a problem when both of our mics are on, where we get that feedback. Dr. Simpson, I had a question about because you do treat families as well, and it seems so very helpful to have a family perspective to anything a child is going through, because of course it affects the family. But I'm wondering how you would weigh in on, many times a patient may only have access to a child psychiatrist, to a child psychologist or psychiatrist. So what kind of advice would you give us as clinicians if we're getting our kids evaluated, then we need to suggest family therapy, just kind of along with it? Like, is that a good rule of thumb to follow?
I think that is my rule of thumb. Is I'm a psychiatrist who, and I'm gonna go back on these slides. I'm a psychiatrist who does therapy, so I, in my mind, am all in one. And if you're referring to a child psychiatrist, you have to know if the psychiatrist does both, because if they don't do both, then either you can refer them to the psychiatrist and let the psychiatrist make the decision, or not. And again, I'll pull this slide up because in if any of this occurs, then a referral is needed. Oftentimes, it is easier to get a person in to see a therapist before me. And because of that, then I had a call this morning at 8:30. Get them into counseling and therapist, and in the meantime, make an appointment to see me as well. So I'm a proponent of at least some psychological therapeutic intervention simultaneous with the psychiatric intervention if the psychiatrist does not do therapy, just period. I'll give an example real quick. My nephew, who I love, TJ, gets a little ornery, and my sister told the pediatrician that TJ was being a little mouthy, and his first response was, "Do you need family therapy? You need family therapist referral?" I said, "I love it. I love it. That was exactly what I would have wanted him to say." So both are needed.
Thank you. I hit my mute by mistake. So we do have a follow-up, and this is what I would think as well. They may be the same books. So what are your main reference books, particularly if you have a primary care person who wants to go into psychiatry, or in this case with the PA or nurse practitioner who's probably trained with a general degree and now wanting to go into psychiatry? What are some good reference books that you could recommend? You're mute.
In terms of theory and understanding, and I've gone back to the references pages, and these are big books, these are textbooks, but I think that they're great books. The Martin, and that is like the Bible, the Lewis Child and Adolescent Psychiatry book, that's the Bible, and also the Schaefer book for developmental psychology. So those are the things that I use. If at all possible, I seek out conferences where I get more learning. So, and I try to read a whole bunch of things, but I do focus my reading on the Lewis and the Martin A book, which is the Lewis Child and Psychiatry book, and the Schaefer Developmental Psychology book. They are very wordy, but that is what I use in terms of just really understanding children and teens.
Thanks so much. And as you can see, we have another question, which is a hot button issue right now about obesity. I don't know about the rest of the country, but here in Georgia, there's a new campaign that's targeting childhood obesity. And in my opinion, the commercials are just mean-spirited. Even the billboards, they're like, chubby, chunky is still fat, that kind of thing. And they always show like a parent and a child. But they're getting at talking to parents about obesity, and seeing those commercials and the billboards make me uncomfortable. And it looks like the person who's weighing in is saying the same thing. How do you approach that to a teen who's already, body image conscious? How do you do that as a clinician?
Well, I think that the main thing that I do is, I wouldn't do anything until rapport has been established. And rapport, you can establish rapport within minutes, but if we're depending on the child, it may take longer. During the assessment, I'm how is school? How are things going? And then it is now. How do you feel about yourself? What do you think about yourself? And oftentimes I will take a piece of paper and I will ask them to write down who they are. And oftentimes they answer with all the great things. I'm nice and I'm funny and I have friends and all this stuff. That's what they usually say. And then I say, okay, let's turn that over and let's do it again. And let's do it for real. Let's do it for real. So let's really get into what you really think and feel about yourself. And I'm hoping that whatever that is on the back page and the front page, that we're going to be able to talk about, and I can help you with anything that I feel like that I can't help you with. So that's how I started. I'm also asking the family, which is often a separate question, question to mom or dad without the patient, about what is going on with the weight. So with them, I really it's helpful for me to have a little background information about how the family feels about food and eating and reward and consequence and comfort and coping before I actually start trying to hone in on those issues with the child. Even though I like to weigh children, if I think that there's going to be an issue with the child being on the scale or any of that, because we try to do vitals at our clinic, then I try to refrain from that. And also asking the parent to bring the pediatric records. That would be helpful. That's always helpful.
Well, thank you, Dr. Simpson. Looks like you've got a little bit of fan mail that has come through. And let me just say, too, thank you for your passion. It definitely shows. We've had a little bit of interaction as we've planned this thing, but now that you've done this presentation, I'm absolutely smitten. I'm going to have to try to get you back on and do something else. So, and particularly the way that you care for the adolescents, that's just so super awesome. So thank you for your life work. Thank you for the price that you pay to be the kind of clinician that you are. You are an inspiration to me, and I'm sure to our other clinicians that are out there in the grind trying to provide good patient care. So thanks so much too for our audience. I don't think we have any more questions for your time and attention tonight. Okay.
Thank you so much. Oh, you're so gracious. Thank you so much. And I am going to head off. Okay, bye-bye.
To the audience person. Sorry, guys. If you would like to have a copy of the slides, you can email me at sajackson@msm.edu. That's SA for Sabrina, Jackson at msm.edu, and I can provide you a copy of the slides. I would like to say as well that many of the resources that were highlighted are on the website, and they will be in the general behavioral health section. Some are under links and some are under tools and templates, so you guys will have access. This presentation was recorded tonight, and it will be available to you on the website in our on-demand section in about a week. So again, thank you so much, audience, for your participation. Thanks to Qualin, who's our IT extraordinaire, for pushing through although the tech difficulties that we had during our warm-up and during the presentation. So thank you. Again, just a reminder, these primary care webinar series is made possible through a partnership between the National Center for Primary Care and Clinical Directors Network. It allows us here at PrimaryCareForAll.org to serve as a resource for you, the clinicians of the National Health Service Corps. Direct financial support was made possible through from the U.S. Department of Health and Human Services. Please note the upcoming events pause that's in the middle of the screen. And I told you about the resources. A CE quiz tab should be popping up as we speak. Please complete it in its entirety to obtain your 1-hour CE credit. Thank you again, audience, for your time and your attention, and have a wonderful evening.